Hello and welcome. My name is Valerie Efue. I am a cardiology fellow at the Morehouse School of Medicine in Atlanta, Georgia. Today, I'll be presenting a case related to the use of intravascular ultrasound in pulmonary embolectomy for saddle pulmonary embolism. I have no relevant disclosures for this presentation. I'll start off with a case which involves a 61-year-old female who presented to the emergency room with complaints of difficulty breathing. And earlier during the day, she had been to her primary care doctor's office and was noted to be hypoxic. In her past medical history, was notable for a stage 4 chronic kidney disease and also a provoked DVT and PE, which occurred 3 years prior. And 3 weeks prior to arrival in the ED, she had stopped her oral anticoagulant. On exam, she was pretty hemodynamically stable and obese, and her O2 saturation was 88% on 5 liters of oxygen. Of significance was some mild respiratory distress and slightly distended jugular veins with bilateral 2+ beating edema, which was noted on clinical exam. Her labs were notable for a creatinine of 1.9 with a GFR of 33, slightly elevated troponin, and elevated BNP, a moderate anemia, and also a decrease in arterial O2 partial pressure. We then proceeded to obtain a chest CT using pulmonary embolism protocol, which showed a saddle embolus as seen on the first image, which was extended more to the to the left PA than the right PA, and there was some evidence of right ventricular dysfunction or strain on both the CT, PE, as well as on echocardiogram as shown on the third image, with an RV to LV ratio of 2. So overall, here's a case of a lady presenting with an acute submassive PE who had an intermediate risk of major bleeding with a Rayleigh score of 4, which translates into a 2.8 risk of clinically significant bleeding. So the decision was made to proceed with a catheter-directed embolectomy over catheter-directed thrombolysis, given her risk of bleeding. And using a femoral approach, we advanced an intravascular ultrasound to the level of the pulmonary artery bifurcation as shown on the first image, which served as a roadmap to localize the clot, which is shown on the second image right here. And once the clot was localized, we then used a 20 French inari flow retriever to manually aspirate the clot. And after manual aspiration of the clot, an IVUS was there was a repeat IVUS at the same level where the clot was initially found, just to make sure that aspiration of the clot had been complete. After aspiration at the PA bifurcation, we then proceeded to the right pulmonary artery with the same process, localizing the clot and using the 20 French sheet, using the 20 French inari flow retriever to manually aspirate the clot, as shown on the second and the third images, to the left PA. There was more clot burden on the left PA, and we weren't able to completely aspirate everything, which was seen on IVUS. And this is a representation of the total amount of clot that was obtained from the left, right, as well as from the common, from the PA bifurcation. So post-procedure, she did report some modest reduction in a mean pulmonary artery pressure from 59 to 53 to 49. She noted some improvement in her breathing, as well as there was some improvement in her oxygenation. The patient developed an AKI on the third day of her creatinine peaked on the third day of admission, but on the post discharge follow-up 6 weeks after, her creatinine had returned to baseline levels. So in conclusion, this case shows that a percutaneous catheter-directed approach is feasible in patients with acute massive pulmonary embolism and also with chronic kidney disease who have an intermediate risk of bleeding. And an IVUS-only approach without the use of contrast to do pulmonary angiography could limit your contrast, your double load of contrast from the CTP and as well as the pulmonary angiography, which could reduce mortality and morbidity associated with contrast-induced acute kidney injury. I want to thank Dr. Sachdeva and Dr. Kumar, who also helped in this case. Thank you.